In fact, some of those people could even go through college. You know, I went to college with a few of those people. Yeah. So next speaker is Christian Webb, Associate Professor of Psychology at Harvard Medical School, and he's the Director of Treatment and Etiology of Depression in Youth Lab at McLean Hospital.
Thanks so much for the invitation. So our lab's work is focused on the causes and treatment of depression in teens. And one area of research that we've been interested in is, can we harness smartphones, this powerful technology that the vast majority of adolescents carry around in their pockets, over 85% of teens, to try to detect depressive symptoms in real time and to intervene with smartphone-delivered interventions. Let's see. So why focus on depression in adolescents? Depression rates surge during the adolescent years. As shown here, these are US data. The red lines are girls, blue lines are boys, the solid lines are non-severe depression, and the dashed lines are severe depression. And you can see this pattern of increase in depression rates during the adolescent years, especially for teen girls. By the end of adolescence, around 15 to 20% of teens will have experienced at least one episode of clinical depression. The figure on the right here is showing depression rates from 2007 to 2017 for teen girls on the left, teen boys on the right, suggesting that depression rates have been going up in recent years. And the light shaded region at the bottom here, importantly, this is showing the percentage of teens with depression receiving any treatment for their depression. And about 60% of depressed teens receive no treatment for their depression for a variety of different reasons. So we need some alternative means to reach teens struggling with depression. There's a huge shortage of therapists. There are not enough mental health care clinicians. There are long wait lists. We know that from lots of research. And digital therapies, including smartphone-delivered interventions, are one means to help bridge this gap. So in our work, we've used smartphones for assessment and intervention. In terms of assessment, rather than solely relying on conventional paper and pencil questionnaires where we might ask a teen to try to recall their average level of depressive symptoms over the past 2 weeks, we've been using smartphone delivered surveys, or ecological momentary assessment, or EMA, where we ping teens multiple times a day to try to get a finer grained assessment of their thoughts, feelings, and behaviors in their daily lives. In terms of interventions, we've also been using smartphones to deliver interventions. In recent years, we've focused a fair bit on mindfulness delivered via apps. And so teens are doing these smartphone interventions via apps, but at the same time, we can use smartphone EMA surveys to track changes in depressive symptoms and also track changes in hypothesized mechanisms targeted by the intervention. For example, to what extent are teens using a mindfulness app actually acquiring and using the mindfulness skills encouraged by the app. And finally, we've also been interested in using passive smartphone sensor data to predict when teens are struggling with heightened negative emotions. For example, data tracking activity levels from the phone's accelerometer, tracking percentage of time at different locations, including percentage of time spent at home from the phone's GPS, phone use patterns, of course, with the consent of the teen and the parent, and the proper data protections in place. And the big idea here is that if smartphone sensors could provide reasonably accurate real-time predictions of states of heightened negative emotions, then perhaps we could swoop in and deliver an intervention directly on a teen's smartphone via text message or pop-up message. So with that overview in mind of how we use smartphones in our work, let me present a couple of example studies, starting with our work on mindfulness apps as a brief and scalable intervention for depressive symptoms, and then ending with our work using machine learning approaches applied to passive smartphone sensor data to try to predict when teens might most need an intervention. So one of the cognitive factors that might be contributing to the rise of depression during adolescence is rumination, which is defined as repetitive and negative self-focused thinking. It's been shown to be a transdiagnostic risk factor in the development of depression and anxiety. There are quite a few studies now showing that rumination prospectively predicts the onset of future depressive and anxiety symptoms. There's evidence that rumination increases during the adolescent years, and we think that mindfulness training, with its emphasis on cultivating present moment attention and metacognitive awareness of your thought stream, including negative thoughts that you're having, might be helpful for teens struggling with rumination. How often are teens struggling with rumination or having negative thoughts? So we've done studies using these EMA surveys where we ping teens multiple times a day to assess, in this case, their thought characteristics. Here's a study here. If you just focus on the top right-hand panel, one of the questions that we asked was, right before you got this survey, were you thinking something negative, something pleasant, or something neutral? If you focus on the teens in yellow, these are healthy teens with no depressive symptoms whatsoever. 14% of the time that we pinged them at random time points, they said, you interrupted a negative thought. For teens with at least some elevations in depressive symptoms, not necessarily clinical depression, but at least some elevations in symptoms, over a quarter of the time that we were pinging them, they said that we were interrupting a negative thought. Now, we're pinging these teens at random time points. So to be spending more than a quarter of your day immersed in negative thoughts can't be good for your mood, which is what we found, not surprisingly. So with my colleague Lori Hilt, we've done a couple of studies and have a couple follow-up studies on app-based mindfulness training for teens struggling with rumination. And so we had an initial single-arm study where everyone got the mindfulness app, and then followed up with a randomized clinical trial where half the teens got a mindfulness app, the same mindfulness app, the other half got a control app. The teens use the mindfulness app for 3 weeks, and they have a higher likelihood of receiving mindfulness exercises, which are brief, 1 to 12 minutes in duration, if they report higher sadness or anxiety on the brief EMA smartphone surveys that we send them 2 to 3 times a day. So our app is adaptive in that sense. If you're reporting higher sadness or anxiety, you got a greater chance of receiving a mindfulness exercise. And across the 3-week interventions, teens were doing about 1.5 brief mindfulness exercises per day. Okay, let me make this a bit more concrete for you. I'm glad this animation worked out. So this is one teen from one of our studies, from our first trial. We're following them for 3 weeks. They're using a mindfulness app about 1.5 times per day. We're pinging this teen 2 to 3 times a day to fill out surveys on their emotions, but also on their rumination, which is our primary outcome here. You might wonder, why is this teen's, whoops, how do I go back? Okay, why is this teen's rumination score going up and down like that so much? That's because they're filling out surveys on their rumination immediately before they do a mindfulness exercise in green and immediately after they do one of these brief mindfulness exercise. So this allows us to look at outcomes over 2 time frames. We can look at immediate reduction in rumination on a 1 to 12 minute time frame, or we can also look at the slope, the cumulative change in rumination over time. For the rest of the talk, I'm just going to focus on the cumulative outcomes. So what we found is in study 1, we found significant reductions in overall rumination over the 3-week trial. Study 2, we randomly assigned the teens to the mindfulness app or the mood tracking app. They had greater reduction in the mindfulness app than mood tracking app. Small samples, we do have follow-up studies with larger samples. But these are just showing averages. I'm really interested in between-person differences, and so in these outcomes. So here I'm plotting, every panel here is improvement in rumination for one teen from our first trial. And you can see there's a lot of variability in outcomes, even if the average effect is that teens do better with the mindfulness app. So if you look at our first teen here, the first teen that we enrolled showed no improvement. The second teen that we enrolled did show improvement. So a lot of variability, and what we were interested in doing is using machine learning approaches applied to baseline clinical and demographic characteristics to see if we could predict which teen is most likely to benefit. We developed the model in this sample, and then we used it to predict outcome for the teens in the second trial, new sample, who were randomized to the same mindfulness app or the control app. And what we tested was, so we fed in the baseline characteristics of these teens in study 2 into the machine learning model developed in study 1. And at the bottom here, you have predicted outcome. As you move left, that's better predicted outcome, a greater expected reduction in rumination. And on the y-axis here, as you move down, that's better actual outcome in the trial. And what you can see is for the teens in green, these are the teens that were randomized to the mindfulness app, better predicted outcome based on the model developed in study 1 was associated with better actual outcome. but not for the teens in the mood tracking condition. So that suggests that the model that we developed in study 1 has some specificity in predicting better outcomes to teens who got the mindfulness app, not the mood tracking app. It's not a general prognostic predictor if you're going to improve. It seems to be a marker if you're going to improve if you do a mindfulness app, at least relative to a mood tracking app. How do we use this to make personalized recommendations? So we won't go into the details, but they're in the papers here, but we developed some thresholds to make more confident recommendations to use the app in green, if you follow here. Cautious recommendation to use the app in yellow. In red, we don't recommend you use the app because you're actually predicted to do better in the mood tracking condition. We found the same pattern of findings for a second outcome measure. And for any given individual, like this individual in blue here, where we generate their predicted outcome based on the model developed in study 1, we can communicate to them before they use the apps. What's your expected reduction in rumination if you use the mindfulness app? 30%. Expected reduction for the mood tracking app, 1%. And then with Richie Davidson's group at the University of Wisconsin, we did a larger trial and found a similar pattern of findings. Last couple slides. What we're interested in doing now is can we use smartphone sensor data, passive sensors, to predict when teens might most need a mindfulness intervention, when they're predicted to be in a state of heightened negative affect. And so we're using data from, as I mentioned, passive smartphone sensors tracking activity levels, location, phone use patterns. Just to give you one example, here's one teen from one of our studies. We followed them for 3 months. And they're getting these EMA surveys on their smartphone a few times a day. And you can see this teen over 3 months is getting these discrete spikes this is showing their sadness levels. What we want to do is, can we use smartphone sensor data, passive data, to predict when this teen is in a state of high sadness? Or anger or anxiety. Those are the 3 emotions we predicted. And we compared a range of different machine learning approaches as well as some simpler approaches, and getting accuracies of about 70 to 75% in predicting these states from passive sensors. So significantly better than chance, but hopefully some room to improve. I won't go into all the details here, but we compared a range of different machine learning approaches. Just one that's worth noting, we compared fully personalized models where we just use your own data to develop your predictive model, versus an ensemble approach where we're searching for the optimal combination of weighting not just your model, but weighting other people's models. If I'm predicting my own negative emotions, should I just use my own model, or should I also borrow some information from other individuals' models? And what we found in pretty much every case was it's helpful to borrow information from other individuals' models. There's been a lot of emphasis on fully idiographic models in the field where everyone's unique. Build unique models for every person if you have enough data, and these data suggest that that actually wasn't as good as borrowing information from other individuals. Very last slide, we're moving now to develop a just-in-time pipeline where we can automatically, in one step, upload the data, process it, visualize it if we'd like, feed the process features into our machine learning algorithm, which generates predicted probabilities of being in a state of high sadness, anger, or anxiety for a given teen, which would then trigger the mindfulness intervention, or you could consider other psychosocial interventions on a smartphone. And I want to thank my funders and collaborators, including some collaborators that are here, Sue Whitfield-Gabriele, who's speaking next, I think. Thank you.
Great talk, Christian. I just had a quick question. Anyways, for the people who use the app and respond to the mindfulness, do you know of any data that suggests, like, people who respond to these short-term interventions, are they more likely to engage with therapy in the future?
That's a great question. So I'm presenting, you could have different models of this where it's an adjunct, right? Maybe you're on a wait list and you're waiting for therapy, and so you get a mindfulness app until you get into in-person therapy. Or you're in in-person therapy and you're using these tools to practice your CBT techniques or mindfulness techniques outside. So I don't know the answer to the question, whether they would be more likely to engage in therapy, but that would be a cool study to do.